Good afternoon, respected professors and teachers. I sincerely thank all the professors and special thanks to my HOD, Dr. Anita Saxena ma'am, for giving this valuable opportunity to present a case in this CSI program. So, starting with my case, my patient is a Mr. RK, 20 years old male, studying BSc second year, resident of Bihar. History was given by himself and mother, and it is reliable. He presented with the chief complaints of bluish discoloration of skin and mucous membrane since 7 months of age, easy fatigability and shortness of breath since 5 years of age, and episodic palpitations for 2 years, hemoptysis around 3 episodes 1 month back. Coming to the history of presenting illness, he was born as a full-term normal vaginal delivery with normal birth weight as told by the mother and asymptomatic till 4th month of age. Then he developed lower respiratory tract infection in the form of pneumonia, for which he required hospital admission for about 5 days. And he received IV antibiotics, after which pneumonia was resolved. However, no cardiological evaluation was done during that time. And as age progresses, mother observed a poor weight gain of the child. And at the age of 7 months of the child, then mother noticed bluish discoloration of lips and tongue while crying and feeding, for which child was shown in a government hospital, Bihar, where after evaluation, he was told to have heart disease, which requires surgery. But because of the financial issues, he was not underwent any surgery during that time. This bluish discoloration of the skin and mucous membrane progressed over a period of 2 years, and after that, the severity of the bluish discoloration was constant. There was no history of sudden worsening of bluish discoloration associated with increased shortness of breath, no history of any hospital admissions for the sudden worsening of the cyanosis, no history of squatting episodes in the childhood. He also had history of easy fatigability associated with dyspnea and exertion since 5 years of age, which is NYHA class 2, and shortness of breath was non-progressive in nature. Shortness of breath was not associated with any paroxysmal nocturnal dyspnea, orthopnea, not associated with chest pain or syncope. And it was not associated with any swelling of the limbs, abdomen, or yellowish discoloration of the eyes. He also had history of palpitations for about 2 years, which were episodic, sudden onset, at rest, which were not related with any activity. There are few episodes and they used to subside after giving an IV injection. However, the exact nature of the medication was not known to the patient. The palpitations were not associated with any giddiness, syncope, and not associated with, and the last episode of sudden onset of palpitation were 4 months back. And he also had history of hemoptysis 1 month back, which are about 3 episodes, and which are 1 week apart. Each episode, the quantity of the blood was around 30 to 50 ml of the blood, and it was not preceded by any fever or weight loss, and it was not associated with any increased shortness of breath or chest pain. So for these complaints, patient was referred to AIMS. There was no history of any prolonged fever, no history of headache, no history of blurring of vision, no history of joint pains. Coming to the past history, no history of tuberculosis in the past, no history of any hypertension or diabetes. Maternal history, no history of any hypertension or diabetes in the mother, and no history of any drug intake or fever with rash during the pregnancy. Developmental history, there was no significant developmental delay. Family history, father expired at the age of 33 years in a road traffic accident, and mother is a manual laborer. He had one elder brother and one younger sister. No history of similar complaints in the family members, and no history of tuberculosis in the family members. Personal history, mixed diet, and he is unmarried and no addictions. Socioeconomic history, he is living in a pakka house with 2 rooms, belong to lower middle socioeconomic class according to the modified Kupaswamy scale.
Can you summarize your history, Vijay?
Yes, ma'am. So to summarize, my patient is 20 years old male with a history of pneumonia at 4 months of age, with poor weight gain in childhood, and there is a progressive cyanosis since 7 months of age, with an history of easy fatigability and non-progressive shortness of breath of NYHA class 2 since 5 years of age. with an history of arrhythmic palpitation for about last 2 years, and recent onset of hemoptysis around 3 episodes 1 month back, with an history suggestive of patient having congenital heart disease with that requires surgery at the age of 7 months.
Why do you say arrhythmic palpitations?
Ma'am, it is non-exertional sudden onset which are used to start at rest, ma'am, and used to few subside to be spontaneously and few with after giving IV injections, and it was not related with any activities.
Okay, so just tell us your hemodynamic interpretation and the possibilities in terms of diagnosis based on the history alone.
Yes, ma'am. So this patient developed cyanosis at the age of 7th month, which is preceded by history of pneumonia with poor weight gain. So likely, I was thinking cyanotic congenital heart disease with which was initially started with increased QP. The symptoms initially had increased QP symptoms like pneumonia with poor weight gain, and after that he developed cyanosis. And the recent onset of hemoptysis also. So
would you like to place him in the congenital cyanotic heart disease group?
Yes, sir.
Okay, then from the history, you have not yet done the clinical exam.
Sir.
Is it suggestive of decreased flow or increased flow?
Sir, patient started with increased QP, sir, because he had poor weight gain along with history of pneumonia that required hospital admission. So I was thinking it was increased QP, CCHD with increased QP initially.
Don't you think that the duration of cyanosis, if you are thinking in terms of an acyanotic heart disease later developing cyanosis,
Sir,
whatever reasons,
Sir.
then looking at the time interval is a little short. That is an odd point, I thought, because there was no cyanosis to begin with, and at 7 months the mother has noticed cyanosis, which would first put your this thing on. Is it cyanotic congenital heart disease or an acyanotic heart disease later developing cyanosis?
Sir, usually acyanotic congenital heart disease developing cyanosis like Eisenmenger physiology, usually with plain shunt lesions will have developed cyanosis in the first decade or second decade, but complex congenital heart disease with both admixture as well as transfusion physiology, they can have early onset of cyanosis, sir. So we initially started with increased QP, then they can develop Eisenmenger later to develop cyanosis.
Your history initially was more in favor of an increased pulmonary blood flow.
Yes, sir.
Why do you say so? Because you've just got one episode of pneumonia and cyanosis occurring early.
Yes,
so
sir.
then when cyanosis is occurring early, meaning at 7 months of age, and increased blood flow situation,
Sir.
what kind of conditions come to your mind which will permit you a survival up until 20 years of age? And when typically a simple VSD Eisenmengerized would we will see cyanosis for the first time?
Sir, actually, simple VSD, large VSD, they to develop cyanosis in the infancy is very, very, very rare, sir. And usually they will develop Eisenmenger by 2 years, and they will develop cyanosis in the first.
The start of onset of PVOD. Full-fledged may develop later, and as you rightly said, the cyanosis comes much later in the first or the second decade,
for a
actually.
high blood flow situation, when you have got cyanosis, which is in infancy.
Praful, you are not properly audible. Be louder, please.
Yeah, within 7 months you are getting cyanosis. So what conditions are coming to your mind? When you say Eisenmenger's, first thing that comes to your mind is VSD pulmonary hypertension, Eisenmenger's, right? So can it be a simple VSD Eisenmengerized?
Unlikely, sir.
Unlikely. So at which of these 3 levels are you thinking about?
Sir, I was thinking there should be not only the simple lesion but also admixture physiology should be there, sir.
So what admixture physiologies do you know of for them to be there in this
yes, sir.
like that?
Like single ventricle or double outlet right ventricle or total anomalous pulmonary venous connection.
Okay, what about AV canal?
AV canal.
Common atrium?
Common atrium and tricuspid atresia with VSD without PS.
No, I think Vijay, common atrium will not develop Eisenmenger so early. You cannot include common atrium in this group, so is AVST. AVST is primarily a VSD plus AST. It will not develop Eisenmenger at 7 months. I think the point that you are missing over here is that the cyanosis has been noticed at 7 months. It's very likely that cyanosis has been there all along. So you cannot discount that cyanosis was not there. Parents don't notice it unless it is, significantly cyanosed. So if the saturation is in 88, 90%, it may be totally missed at the bedside.
Yes, so can this be a TAPVC? Let's often just talk about, can this be a total anomalous pulmonary venous connection?
Yes, sir. It can be total anomalous pulmonary venous connection can be a possibility, sir, based on the history.
Vijay, I missed one thing. You have mentioned that the child required surgery at the age of 7 months.
Yes, sir.
Is there anything revealing from the history whether the nature of the surgery was given to him or parents, that he will require another kind of surgery later on, or this was the total surgery done? Any idea was given in the history? I think you can extract that history at least.
No, sir. Actually, mother was able to tell that the surgery was required, but she didn't know the exact nature and she didn't elaborate like.
Is she sure that it was a heart surgery?
Yes, sir. She told it was a heart surgery. He had heart disease and required surgery.
And she was not told anything about the step 1 surgery or step 2 surgery?
No, sir.
Okay.
Actually,
why can't this be a low pulmonary blood flow situation? I am telling you, this is garden variety tetralogy of fallow. So what is against in all this history that you talked?
Sir, tetralogy physiology, the typical physiology, like it will be VSD with pulmonary stenosis. So here the patients to be started with increased QP symptoms like pneumonia and poor weight gain, sir. So that is against of
pneumonia, poor weight gain. He has had one episode of pneumonia and he is the undernourished person. That's about it. So what is there? Where is there any history suggestive of any heart failure like physiology in childhood?
Another thing, Vijay, as far as saying about any other history of heart failure, that is thing. Another thing I am mentioning here, that you are telling that they are from the lower socioeconomic country status. So it could be nutritional deficit as well, rather than failure to thrive due to other reason.
So, are you totally ruling out tetralogy of fallow? I am telling you that cyanotic heart disease in the adult, and this, because there are no squatting episodes, because there are no spells, is what you want to say?
Yes, sir.
Then having said that, do you get squatting episodes with Eisenmenger physiology also?
Yes, sir. We can.
Right?
Child can get squatting episodes even in Eisenmenger, sir, but it is very less percent. Around 3 to 5% of the children can develop with Eisenmenger can develop squatting episodes, sir.
So what is against tetralogy of fallow here?
So I was more not putting tetralogy of fallow because of the episode of pneumonia with poor weight gain, and there were no squatting episodes or cyanotic spells, sir, in the childhood.
One episode of pneumonia, Vijay, again can be happening in any child, with or without heart disease in our status, and whether it is recurrent LRTI or something like that.
No, sir. Only one episode, but that required hospital admission, so definitely it is significant. But if we disregard that pneumonia, if we attribute that pneumonia due to poor nutrition, then definitely
there are many cases in the pediatric ward without any heart disease. They are getting admitted with RTI and getting discharged subsequently.
So Vijay, I think you should not rule out cyanotic heart disease with reduced pulmonary blood flow. Although your first diagnosis is right, it should be considered as increased pulmonary blood flow. But remember, the reduced pulmonary blood flow group is far more likely to survive to this age.
Exactly.
And therefore, please don't disregard that diagnosis. You can put it as number 2, but you cannot say that you will rule it out based on the history.
Yes, I do agree. I think that's a very, very valid point. Okay.
So, you've got, this is your differential diagnosis?
Yes, ma'am. So second possibility I'd like to keep top physiology also, as you said, ma'am.
Yes. I think you should. And of the increased pulmonary blood flow going on to Eisenmenger, like the one you mentioned, are fine. you really cannot have a preference of one over the other.
That's a typo out there. Decreased. You mean increased?
Yes, it is decreased now. No? It is Eisenmenger now. He started off as increased.
Now you are telling. Okay.
Yeah, it decreased now. So it will also come as decreased pulmonary blood flow. But what I'm saying is between the various differentials that you've given, there's really not much to choose from. But I would like to ask you in terms of survival. I think at this point of time, you have to just think in terms of survival, that which is likely to survive. For example, you haven't placed transposition over here, and I would say rightly so, because that has the worst survival.
Worst survival.
Yeah.
Another thing regarding truncus. Do you think surgery can be done in a peripheral center with truncus surgery? That's a bit difficult surgery.
Anita madam, here DORV VSD with transport arteries. You are actually meaning a subpulmonic VSD, right?
Yeah, are you meaning toxic
then along with that will be transposition. I don't think that is first on cards. If you say transposition is not first on cards, this is DORV VSD non-transposed vessels.
Yeah, but they definitely have a better survival than the transposition.
They have, but you shouldn't be mentioning DORV VSD with transposed great arteries. That's same as transposition.
Yeah, it is Tausigming he's talking about.
This was the Tausigming. Yeah.
It's Tausigming he's talking about, which definitely has a better survival than the TGA VSD itself. Okay. So DORV definitely is better than TGA. But regarding truncus, I don't know, Vijay, you want to answer that question? Can it be operated in a, is it easy to operate? Would you advise surgery for a truncus?
Ma'am, at the age of 7 years, likely he might be got operated, but not at the periphery center, ma'am. He might have referred to some tertiary care center where.
You mentioned 7 months or 7 years?
7 months, sir.
So I don't think it is an easy surgery. If it is an increased flow situation, only bending something like that, though we do not know about the center. That type of surgery are done in the peripheral centers.
I think
I would like to put single ventricle ahead of truncus.
I would
maybe the last one.
Single ventricle
has a better survival overall.
Okay.
Go ahead, please.
Go to the examination now.
Coming to the examination, patient conscious, oriented, comfortable at rest, thin built with BMI of 16.4. kg per meter square, and on general physical examination, patient is polycythemic. There is a uniform central cyanosis with grade 3 clubbing both upper limbs and lower limbs. There was no icterus, no pedal edema, no lymphadenopathy, no markers of infective endocarditis with normal dental hygiene. Coming to the vital examination, pulse rate was 72 per minute, regular, normal volume with no special character. All peripheral pulses were felt, no radial or radiofemoral delay. BP, right, blood pressure was right upper limb 120 by 80 mm of mercury, with right lower limb 128 by 78 millimeter of mercury. Respiratory rate 18 per minute, regular, abdominothoracic, and temperature febrile 98.8 degrees Fahrenheit, right axilla. Saturation right upper limb was 81%, left upper limb was 80%, and right lower limb is 81%. JVP was not elevated, and the hepatojugular reflex was negative. Coming to the cardiovascular system examination, on inspection, trachea appears central, no precordial bulge. Apical impulse is seen in the 15th intercostal space in the midclavicular line. Parasternal pulsation seen in the left, second, and third intercostal space. There were no epigastric pulsations, no dilated veins or scars.
Did you search for operative scar?
Sorry, sir?
Did you search for a operative scar well?
There were no scars, sir.
No. See, in the conditions that you have described, till up to the JVP, can you rule out one condition depending on the JVP findings? You have listed some differential diagnosis. So, if the JVP is normal, can you rule out one of the conditions? Because you said tricuspidatory is one of the conditions. The JVP is absolutely normal according to you. So probably tricuspidatory can actually be excluded from this condition, isn't it?
Yes, sir.
Okay. Yes. Like if your JVP written is not elevated, then I would consider that tricuspidatory comes much lower in the list of differential diagnoses that I would be discussing. Okay, go ahead. So, on palpation, trachea was central, apex bit felt in the 5th intercostal space in midclavicular line, LV type, heaving character. There was palpable second heart sound.
Systolic thrill was present in left third and fourth intercostal space with grade 2 parasternal heave present. On percussion, right heart border retrosternal and left heart border correspond to apex. Left second intercostal space was dull. Liver dullness felt in the right fifth intercostal space with liver span of around 10 centimeter and trough space was resonant. And coming to the auscultation, S1 was normal, S2, P2 loud with narrow split S2.
Can you hold for a minute? Just from the palpation, do you think is univentricular pathology or a biventricular pathology?
Sir, it is LV type with heaving character, likely it is biventricular pathology, sir.
So
No,
from only heaving apex or parasternal heave is also giving some clue?
Yes, sir. Parasternal heave also indicates RV overload along with the LV heaving type of character. So both including.
Could you locate any zone of retraction in between?
Sir, there is a middle retraction from the.
Are you sure about it, or on my asking you are saying it?
No, sir. Based on that only, I thought it is LV apex.
No, hang on 1 second. At this stage, single ventricle, madam said that would be a more commonness to survive up till here. Now, can this be a single ventricle? At this stage, let's not go to your auscultation or nothing.
Sir, as Sarah asked, I'm able to feel the LV apex with heaving character along with medial retraction, and it was not continuous with the left parasternal pulsations with grade 2 parasternal heave. So likely it suggests of biventricular pathology, sir. We can rule out single ventricular pathology.
I think, Vijay, that is being, I would say, very, very dogmatic about it. Tell me the conditions of cyanotic heart disease where you have an LV apex. Just enumerate them.
Yes. Ma'am, tricuspid atresia and single ventricular with predominant LV morphology are those conditions which are having restrictive ESD like DORB.
Yeah. So I think you should not say that you can rule out single ventricle or you must have two ventricle physiology. I think having an LV apex is very unusual for any cyanotic heart disease, and therefore you should restrict yourself to tricuspid atresia, even if JVP is okay, and single ventricle.
And AVSD with predominant left AV also.
So if it is tricuspid atresia, how he should feel the parasternal heave?
Yeah, so that's what I'm saying, that these are, having a parasternal heave, whether it is in continuation with the apex is something that you also, somebody asked for. So having parasternal heave and LV apex is a very unusual finding in a cyanotic heart. It's possible that he may be wrong, and therefore I would not put all my money on left parasternal heave. I would be more confident of the apex than of anything else. And therefore again, I would say that please do not make it two ventricle just based on this finding.
Again, single ventricle wise, that second heart sound, second space pulsation, you're palpating a second space something there. What about great arterial relationship for the kind of single ventricle that you are expecting? Is it a malposed aorta, or are you talking here about Holmes heart, or are you talking about normally related great arteries? Let's go along that it is single ventricle at this stage. You can't be dogmatic as what madam says. So what do you expect here? In the second left intercostal space, are these pulsations of a malposed aorta or a pulmonary artery there?
Sir, with overall case scenario, I was thinking it is pulmonary artery only, sir.
Okay.
With,
now tell me, in a single ventricle, what kind of malpositions are described of the great arteries? The commonest single ventricle that you see, what is it like? What do you get to see? You heard about outflow chambers, you heard about malposed great arteries. Is that right? So
yes.
What do you get to see when you get single ventricle PS, for instance?
I'm sorry, sir. I'm not.
Vijay, how often you get normally related great arteries in single ventricle?
Single ventricle.
First answer that question.
That usually Rare, ma'am.
Rare. So it is about 3% or so. So of these 95-97% which are left, you obviously have only a couple of ways that the greater arteries could be malposed. They could be demalposed, they could be L malposed, or they could be side by side. So which is commoner of the two, and why we are worried or why we are concerned about second space being dull?
So if the left second space is dull, then likely maybe the second space it will be aorta, ma'am.
Yes, so in patients of pulmonary stenosis, here of course you have an argument to say it could be pulmonary artery because you are talking more in terms of pulmonary arterial hypertension.
Yes.
But in a patient who has pulmonary stenosis, if you have second space which is dull, it is likely to be L-post aorta.
L-post aorta.
Of 85-90% and come on to the adulthood. Holmes heart is itself very, very rare. I mean, it's, as I said, it's less than 5%. Therefore, based on that 5% to say that people who are surviving are likely to be Holmes heart will be tough to say. So I would say that most often single ventricle L-post aorta.
S1 was normal, S2 P2 loud with narrow split S2. There was very loud, long grade 5 ejection systolic murmur along the left sternal border in third and fourth intercostal space. Harsh in character with mid-systolic peaking and radiating throughout the precordium. And there were no other sounds and no murmurs at the back. And other systemic examination was normal.
Situs, clinically situs, solid test.
Yes, yes.
Did you get any click?
No, sir, I couldn't get any click, sir.
Okay.
So, why did you put DOR with a restrictive VS as the first possibility?
Sir, the cyanotic congenital arteries with LV apex, which is having heaving character, likely it has to be restrictive VSD, sir.
Vijay, why it is not tetralogy?
Ma'am, there is a clear-cut P2 loud with palpable P2 and very loud, long, harsh ejection systolic.
No, what you are hearing as P2 is A2. It is not saying that I am P2. It could be A2. Loud A2 is well described in tetralogy patients.
Again, it comes to a second stage
and palpable P2 that cannot be expected. And,
no, Vijay, my point is what you are saying palpable P2 is a juxtaposed or dextroposed aorta, relatively anterior aorta that you get in tetralogy with overriding. So is A2 not loud in tetralogy? It could be A2.
It will be loud.
It could be A2. Why are you saying it is P2?
But two features. One is predominant thrill with this harsh quality, very long ejection systolic murmur.
Patient is not very blue, so you have a loud murmur. Typical tetralogy. Because what the diagnosis you are making is much rarer than tetralogy, no? You have to think in terms of the likelihood of a diagnosis.
LV apex also.
Yes, that is what you didn't say. So you must say. Yes. That is why I was giving so much emphasis onto LV apex. That apex being LV is a very, 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 very important finding in any patient of cyanotic heart disease.
I would have thought that you would put a single ventricle physiology as the first possible rather than DOR. DORV I agree, but statistically I think probably, Anita can correct me, statistically I think single ventricle probably would be a little more frequent than DORV.
You have mentioned NSR, that is, I think it is normal sinus rhythm.
Yes, sir.
Is it so?
Yes, sir.
So from the clinical exam, you examine the pulse, you examine the JVP, etc. So how do you say it is a NSR, not other kind of regular rhythm?
Sir, based on regular rhythm only, I put sinus rhythm, sir, but it can be like junctional rhythm with regular. Yes, sir.
So, how can it be junction rhythm? Are you not seeing A followed by B in every JVP?
Actually, I couldn't appreciate the waves properly. JVP is not elevated. Even in the lying down position, I was not able to appreciate the waves properly.
So you don't see unless you appreciate JVP.
So
you
is he dehydrated that even in the lying down position, he is 20 years old? Do you think he is dehydrated that you couldn't look into the neck vein or any other problem in the neck is there so that you could not examine the neck vein? It's not a baby.
There was no problem with the neck, sir, but I couldn't appreciate properly, sir. So,
see, if you cannot appreciate JVP, you cannot write NSR.
How sure interpretation is only regular rhythm of such rate. Huh?
okay.
How sure are you regarding the split also? Usually in most of the cases it is very only a single second sound. So you have emphasized on the split second sound.
Sir, it appears narrow to me, sir. There are two sounds definitely with narrow.
Okay.
So if you're very sure of the second R sound, I would agree with your diagnosis, but very often you are not, and therefore it will be good to keep single ventricle PS or a tetralogy like condition with such a loud murmur. Such a loud murmur is, something which is very, very rare within Eisenmenger physiology.
And why do you suspect PVH to be there?
Sir, patient is having NVH class 2 symptoms that can be due to cyanosis also, but I'm suspecting a restrictive ESD, so likely it should have at least mild PVH, sir.
No. What is your symptomatology suggest? You categorically said no orthopnea, no
PMD, yes.
Yeah. So what else can clinically? There's no way to try to diagnose that otherwise, no. Just to guess PVH on the basis of what you think is a restrictive ESD, etc., is not on.
That's why I put query mild
But
PVH.
you said patient is dyspneic. So could dyspnea be because of anything else other than PVH in this case?
Yeah, the sinuses, hypoxia itself can produce the NVH class 2.
So interpret PVH, dyspnea as PVH is okay for an acyanotic person, but for a cyanotic patient, it's not a good idea.
Yeah.
So there are several pointers.
Could you just go back one slide and just tell me the auscultatory finding? Just 1 second. Very loud, long, grade 5 ejection systolic murmur. Okay, good. Yeah, come back to that diagnosis, please.
So Vijay, I would still keep one diagnosis, the diagnosis of tetralogy. For the LV apex, you need not keep tetralogy itself, but you could keep single ventricle or an AVSD with the dominant being left ventricle with pulmonary stenosis. Because having such a loud murmur, grade 5/6 in a cyanotic patient, you should not ever move away from tetralogy. If you don't diagnose tetralogy, you're probably not going to be right 90% of the time. So this is a rare diagnosis that you've made, and rare diagnosis should always be with the differential diagnosis.
This degree of murmur we get in very relatively, so-called pink fallow or similar type of situation where PS is minimal. So I think everything is not matching.
Yes, I agree. I think having such a loud murmur, in fact, there is a question from the audience also that how do you diagnose Eisenmenger syndrome in somebody with such a prominent systolic murmur? And that is the question that everybody is asking. We agree with you, Vijay, that you can explain it by a restrictive ESD, but restrictive ESD is a very rare situation in a DORV, much less than a tetralogy situation, and therefore it should come only as a second diagnosis. That is all I was trying to make a point. You may be right having DORV restrictive ESD, but that should not be your first diagnosis.
So in a cyanotic, if you're saying 5/6 murmur, it has to be necessarily low pulmonary blood flow situation from this thing. I don't know why did you ever go down this line of a high blood flow situation just on one episode of pneumonia. When in the history there was nothing to go along high pulmonary blood flow situation otherwise. Yeah.
One thing is that you said there are pulsations in the second left intercostal space. If it's a reduced pulmonary blood flow situation, can this happen?
Sir, abnormally dilated pulmonary arteries like top with absent pulmonary valve can have the pulsations.
But then the murmur will not be different.
Typical.
Different years are saying that because you are fighting
not as palpable. In an absent P valve, the pulsations are not as much palpable as they are. You might get dullness there. But that's a low pressure pulmonary artery, right?
So this is your provisional diagnosis. Any differential?
Sir, I thought because of I gave lot of money to heaving apex, sir. So with heaving apex, I
No,
can't
you
put
can. Why not
any
single
other
ventricle with
diagnosis.
PS?
That's what I
ventricle
said
PS.
initially. My first choice would have been a single ventricular physiology with an LV type of apex rather than a DO with
LPS.
just less, especially with this murmur, which is so loud. See, if you are putting restrictive VST, then your explanation for pulmonary hypertension and all will be again a little tenuous.
And
another thing is that
PS again is with malposed great arteries by and large, right? So that pulsations and all, everything could be the malposed aorta, Paul.
Another thing is that whenever you are giving a single diagnosis and these are not matching with any fixed diagnosis you have given, so either there are differential or you have to discuss the diagnosis. You cannot diagnose it properly. So there are certain probabilities or possibilities you can discuss. So you are at the one point you are giving only one diagnosis, and the other hand we are finding that the findings and history are not matching. So it is a difficult situation.
Yeah, I agree. I think the first diagnosis to me will be single ventricular pulmonary stenosis with an L post aorta, which can give you pulsations in the second left intercostal space, which can give you LV kind of apex. Yes, the history is a little odd in terms of failure to gain weight, but as we discussed that it can happen in our sort of population that we deal with, and therefore putting all your money on that may not be a good idea. But to have a grade 5 murmur in an Eisenmenger is the most unusual thing, and therefore you should make it as a second or third diagnosis.
Another thing, ma'am, is that if it's a univentricular heart, he has to revise his diagnosis of finding up this zona medial retraction. The whole thing should be continuous from right to left.
Yes.
I agree, but I think between the various signs and history that we have, we'll have to pick and choose which one we take as of more significance compared to those which can be ignored. So I would say that to have grade 2 left parasternal, I would go back and check if I'm right or not. Having an LV apex is to me a very, very
the other thing is that maybe one or two findings he has made it wrong. That one or two findings is not.
That's what I'm saying. Like he's saying narrow split with a loud P2. I can interpret it as just a loud single second heart sound being A2. And sometimes when you have a very loud heart sound, then you may have a little bit of a reverberation with it, which may appear like, you cannot like put all your money on that.
Another thing, Vijay, I just pointer, I'm not saying that diagnosis is there. In truncus we get the reduplicated second sound, but it is no, truncus is not matching.
Truncus here would have necessarily had an ADM there along with it. Truncal regurg would have been
no, I told it is not matching. Yeah.
In the adult, there are no diastolic murmurs at all, right?
I think it's the most important point in the physical finding is that LV apex, which you are very sure of. I think as Dr. Anita said, this is one solid finding where probably there will not be difference of opinion between people, and also the second thing is that murmur, where very loud murmur you cannot miss. So these are 2 points which we have to bank your diagnosis on. So that's why I was initially thinking that with Dr. Anita that it would be a single ventricular physiology as a more likely possibility than DORV. Okay, I think.
Vijay, you have a chance now. You can have another diagnosis. So I would suggest that you make another diagnosis in this particular case. What it would be?
It will be like CCHT with decreased QP, single ventricle with PS, and then NVH class 2, no CHF and no infected endocarditis.
Yeah, I mean you should think of tricuspid also one can think of, but a little little unusual with the JVP being absolutely normal in an adult. Although in a child JVP can be normal, but in adult having normal JVP is a little unusual. And also tricuspid atresia has a worse survival than single ventricle. Okay, shall we go to the investigation? Yeah. You can stop sharing, Vijay.
Yes.
So chest X-ray PA view with the distance between with slightly rotate to the left side with good inspiratory film and with adequate exposure, showing CT ratio was around 0.5. There was no cardiomegaly, and the LV apex is looking like LV, and there was no eye enlargement, but cardinal angle appears slightly enlarged, maybe around 90 degrees, likely maybe LE enlargement, and pulmonary trunk is very prominent, with right descending pulmonary artery also prominent, and there was peripheral proning, sir, suggestive of PAH, and
is there PBH?
Looking like there is slight cephalization is there, ma'am. So likely some PBH.
Are you sure about cephalization, or these are branches of pulmonary artery? How do you differentiate?
Sir, we should trace along with the bronchus, sir. If it is going along with the bronchus, likely it is pulmonary arteries rather than the pulmonary vein.
Can you trace along with the bronchus? Is there any bronchial marking? Because their translucent shadow, until unless something there is to trace the bronchus, it becomes difficult. Yes. Another thing, you could retrace back the pathway of the vessel. Around veins.
I think there is a cephalization in the upper part of the lungs, and therefore, and they're not looking like pulmonary artery branches the way they're going. You know, those typical reverse mustaches as we talk about.
Yeah, probability is there, but is there any way to be dogmatic? That is the thing.
No, I agree.
Yeah, because on the one side there is so much of PAH, and at the same time PBH is still there. So again, this should be a very complex pathology. Yeah.
I think if
have you measured? Of course, you are not having the scale. RPA diameter, lower.
Vijay, why do you say RPA is dilated? Based on what?
Ma'am, it visually appears right descending pulmonary artery is dilated and sudden tapering was there. So
no, when do you say it is dilated? What is the definition?
We should measure just 1 centimeter below the hilum. If it is more than 17 centimeters in male and 16 centimeters in female, it's suggestive of dilated.
You think these measurements hold true in digital X-rays as well, when there is no scale around?
No,
so how do you diagnose it as dilated? You have to compare it with some part in the lung, in the X-ray itself.
So compare the bronchus.
Yes.
Bronchus.
So you should say that, because having 1 centimeter or 17 millimeter is something that you won't be able to say in a digital X-ray.
Yeah.
So and then you also said tapering of the right pulmonary artery, descending pulmonary artery. Yeah. Which is suggestive of
severe PH, ma'am.
Yeah.
So but peripheral vascular markings are well seen, no? If you look at the right side and left side.
It appears actually prone, sir. Peripheral 1/3, it is like very barely visible.
I think the question over here is between PS and PH, because this is one of the two diagnoses we are considering. We are not really considering large flow situation without PH over here or without Eisenmenger. So between the two of them, I think it's quite clear this is unlike a tetralogy X-ray or a tetralogy physiology X-ray. It's more in favor of an Eisenmenger X-ray. So between the two diagnoses that you made, Vijay, I think you need to stick more with the Eisenmenger physiology rather than a tetralogy.
Can you see the aortic?
Yes, sir. Actually, just above the right atrium, we can able to see the ascending aorta and Just about the pulmonary bay.
No, you are being asked a very specific question about aortic arch. Which side aortic arch is it?
Left or right?
Left side, sir.
Why do you say that?
Ma'am, there is a indentation on the left side, ma'am, on the trachea.
So that's a simple answer.
Yeah.
Okay.
And there is no right atrial enlargement. Again, tricuspid atresia, one point against the tricuspid atresia again would be an absence of a right atrial enlargement. So it may be a very soft sign.
Only thing is that if you have juxtaposition of atrial appendages, then the RA kind of goes away from the usual. It comes behind the sternum, so you may not appreciate RA enlargement.
Yes.
If it is juxtaposed.
Yes.
Can you appreciate certain prominent end-on appearance of the pulmonary artery branches?
No, sir. There were no prominent end-on vessels. I'm able to appreciate there.
Near the right hilum?
Actually, the X-ray is not actually what I was really expecting. It's slightly odd X-ray.
Yeah. There are some end-on vessels in the right hilum. I agree with that.
Pointing out.
And therefore, again, it points more towards Eisenmenger situation.
And as there is history of congenital, surgery in the 7th month of age. So, is there anything to be looked on the ribs also?
He hasn't had surgery. He was only advised.
Surgery.
He was only advised.
Oh, acha.
Okay.
Okay, ECG. Can we have the ECG?
1 minute, sir.
For channel ECG showing the speed of 25 mm per second with normal standardization. With lead V1 showing P wave upright and AVR showing negative P wave, so situs solitus, and normal R wave progression, so levocardia, and sinus rhythm with QRS axis, lead 3 is biphasic, so lead 2 also positive, so likely 45 to 60 degrees normal axis with there is no right atrial or left atrial enlargement, and R wave in V5, V6. So evidence of LVH, but there is no strain pattern, and V1 is not showing any predominant R wave, so no RVH.
But also you should say no monomorphic complexes like you sometimes see in single ventricle patients.
Okay.
There is a clear transition in V2, V3.
Yeah. Sudden transition.
There are Q waves in 2, 3 and AVF, and in V5 and V6. Is there any? It's a little odd. I don't know how to explain that.
2, 3 AVF Q waves indicates clockwise rotation, which you used to see in most of the congenital heart disease.
I think Q wave in V5 and C6 and an R in V1 will probably rule out, atrioventricular discordance or ventricular inversion. Yeah. Because you were considering about single ventricle with L-pose aorta, you would expect absence of, you would not expect.
What goes out now? Everything else is out, right? Meaning
after the ECG and X-ray, in the backdrop of the clinical history and findings, which diagnosis would you like to keep in after seeing the ECG and X-ray?
Sir,
one thing everybody was thinking about, top situation. Do you think it is still there?
No, sir. Unlikely it is top, and on X-ray it is more of Eisenmenger, looking like Eisenmenger physiology, sir.
Okay, Eisenmenger physiology secondary to?
Secondary to
with a split-second sound.
Yeah, but but you have a normal access, you have no definite evidence of RVH.
That is not expected, sir.
These are all unexpected things in an Eisenmenger, isn't it?
Yes, yes.
R-dash in V1, that's the only RV that we have here, right? And also S in V6 going till there. So is it biventricle, this thing?
Yes. See, if you look at V5, V5 I think it's Catheterization something. B4, V5 biventricular.
Like an Eisenmenger patient. So what comes to mind? Can this be a ductus arteriosus Eisenmenger? Just the ECG.
PDA. So presence of Q waves in lateral leads usually suggest of PDA with Eisenmenger, sir, like V5, V6. So it can be.
No, I wouldn't agree with that. You should have right axis deviation. You should have dominant right ventricular hypertrophy. If somebody is turned blue, there's no question about LV volume overload staying over. So you should have RAD and RVH pure if it is Eisenmenger, whether it is VSD or PDA. I mean, if you have LV forces, then patient should not have been blue if it was PDA PAH. I think I would still say it fits with single ventricle because single ventricle can have any type of ECG. So I would not rule out single ventricle of with this ECG. Yes, X-ray is against tetralogy. I would agree.
Actually, at times the outflow tract in the single ventricle, actually basically they are known as the univentricular pathology, can produce some right-sided impression besides the left-sided. So there may be apparently two ventricles due to the non-dominant ventricle. So yes, this may be still a univentricular heart that has got different types of univentricular
but still
heart.
With a bulboventricular foramen causing that murmur. This is a PSPH scenario. Is that what you are hinting at? Meaning, where is the murmur coming from?
No, we are saying, what I am saying is that in single ventricle, the ECG can be anything, and therefore of the two diagnoses that he made, single ventricle PS could have been a diagnosis, but X-ray is against it. X-ray is pointing towards Eisenmenger syndrome.
One question to all the examiners. Should we or can we entertain a diagnosis of Eisenmenger's without any right ventricular forces as if this is
exactly? But he is blue, absolutely blue. The child is
so the diagnosis must be something else.
So Vijay has made it Eisenmenger with restrictive VST, and once you think of restrictive VST, then you can have LV forces which will become dominant, and if LV is more dominant than the RV, then ECG may not show RVH despite RVH being there. That's what I think he is trying to explain it. So simple Eisenmenger, you're absolutely right, should show right axis deviation and right ventricular hypertrophy. That's perfectly fine. But if you have something on top of it, like in this particular patient, then LV forces may become more dominant, taking away the RV forces.
My own impression was more in favor of a single ventricle. With this ECG being very, very odd.
The thing is, if you take single ventricle PAH, then again, how do you explain such a loud murmur?
At once the Q is there, that in V5, V6, there is a Q and everything, septal forces are there, and then there is a single ventricle at all in, I do not understand really.
No, you can have single ventricle without inverted infundibulum, and therefore without inverted outflow, and therefore you may have Q waves like you have in normal people.
It brings us to that Holmes heart, what I was talking about.
No, deposition of the aorta.
Normally,
not Holmes
great arteries, that X-ray is suggestive of a normally related great arteries.
Yes, that's what I'm saying. X-ray and ECG together do not fit in with single ventricle. I agree.
Let's go ahead.
This is, I think, you've got another ECG?
This, I think, with half standardization.
Oh, okay.
Okay.
Yeah.
Okay.
Describe this as it is being done. Describe the echo as it is being done.
Yes, situs solitus.
Yes.
Yes. Situs solitus levocardia with I think subcostal fourth member view. Red Doppler across the interatrial septum, ma'am. Yeah. There is no ASD. typical 4-chamber view showing cuspid wall on the right side because the septal attachment is seen. So normal avic concordance with I think left ventricle is hypertrophied, and Doppler across the tricuspid wall there is no tricuspid regurgitation. And, mitral wall also is normal. There is no MR or MS. There is a turbulent flow across the intercalateral septum from left. I think it is with bidirectional flow.
Yes.
What is the morphology of the RV?
RV looks slightly trabeculated when compared. Left
RV is normally trabeculated. Does it appear to be hypertrophied or normal thickness?
Sir, RV also appears slightly hypertrophied, sir, but I would like to measure the thickness.
Free wall, you can see it's so thick, isn't it?
Yeah, thickened.
See such a free wall.
So, vessel arising from the RV. And whether it is bifurcating or not, I am not able to appreciate properly. So this is R.
Okay, you have not been able to identify the great vessel, but the two great vessels, they are appearing from the same ventricle or
Yes,
yes,
sir. Initially, the first vessel also arising from the RV. Now also the one more vessel is arising from the RV only, sir. So looking like both the vessels are originating from RV, sir. Looking like.
Where is the other vessel's origin? I didn't see that properly.
Uma, can you show the one without color where you are sweeping from one vessel to another?
Yeah.
The previous one, please. Yeah, just show this one. So this is one.
One, yes.
And then the other one comes.
Yes. Okay, fine.
The turbulence across the VSD with I think predominantly left to right, sir. So
the LV is unusually hypertrophied.
Hypertrophied, yes, sir.
Yeah,
Significant hypertrophy.
Restrictive VSD.
The VSD around 6.3 mm. Gradient across the VSD is around 87 mm of Hg. So LV pressure will be like its systolic VP is 120. So around more than 200 mm of Hg, sir, LV pressure. And LV ejection fraction is around 47.8 with dimensions left ventricular diastole 39 with systolic is 39 with ejection fraction of 47%.
What is the LV posterior wall thickness?
So it's around 14 mm, sir.
You have not been able to clearly demonstrate the vessel which is bifurcating,
yes,
isn't
which
it?
one, whether it is bifurcating or not.
That is what a little troubling.
Yes. This is.
Is the VSD dedicated to any artery or not? Is it subarterial or away from the arteries? VSD?
Look away from the artery, sir.
Vijay, supposing there are two vessels, you are not able to demonstrate the bifurcation.
Ma'am.
One is larger than the other. Which one would you call, which one is likely to be possibly pulmonary artery, and which one is possibly aorta? There is no turbulence in any vessel.
The vessel which is larger, more likely aorta, ma'am.
More likely aorta.
No. You
In a patient with no pulmonary stenosis,
Oh, in this phase,
we are talking of a patient like this one where Uma is unable to show us the bifurcation, but she's showing us two vessels.
ma'am.
None of them have any turbulence. That you've seen. They're both opening very well. So which one is likely to be PA and which one is likely to be aorta?
Which one more dilated because of severe PH, likely pulmonary artery?
So if there is no PS, there will be PH.
PH.
In a cyanotic patient, you have PS or PH.
Yes.
Therefore, the larger one should be called pulmonary artery or likely to be pulmonary artery. Of course, you should look at bifurcation, but this is just a guess.
Pulmonary artery also.
Has it the suprasternal view and the aorta has been shown in the suprasternal view?
In such a situation, one view that you would use is a suprasternal view where the aorta happens to be always the superior vessel. So that's also something which you can do. Has it been done?
Yes, sir. I will show it in the next slide, sir.
Okay.
Yes.
So pulmonary artery, which is more dilated, so is left and anterior to the aorta.
Yes.
So normally related arteries.
Here you can
Here it is bifurcation. Yes, yes, sir.
Yeah.
Dilated PA with bifurcation. Okay.
Yeah.
Clearly.
And what is the aorto-pulmonary relationship now?
Now also it is pulmonary artery is left and anterior, sir. So it is normally related.
It may not be very anterior because when she was showing both the valves,
they are almost side by side. They are almost side by side.
Previous view showed it better. At the valve level, we could see both were more side by side.
Correct.
That's a point in favor of a double outlet.
There is
the vessels are side by side.
Bilateral coni there, right? Meaning when in your long axis shots, they were so remote from the mitral valve.
Yeah.
There is a mild pulmonary regurgitation with LV function looks normal biventricular function.
And biventricular hypertrophy.
Hypertrophy. Arch left arch only.
Yes. No coarctation.
There is no coarctation, and there was no turbulence like PDA.
In PAH situation, what are the difficulties in diagnosing PDA by echo?
Sir, because of the severe PAH, there will be equalization of pressures, so there won't be any flow, sir, and there won't be any turbulence, so we will not be able to pick up the PDA.
Just stop, Uma.
Yes, ma'am.
I want to ask Vijay, now what is your diagnosis?
Ma'am, it is situs solitus with levocardia, cyanotic congenital heart disease with decreased QP, and DORB with side-by-side related great arteries with restrictive VSD with a gradient of 87 mm of HT. Severe PAH, likely Eisenmenger physiology with NYHA class 2 with normal sinus rhythm, with no signs of infected endocarditis and no feature such of congestive heart failure.
So if you're saying that he's likely Eisenmenger, would you like to catheterize him? Because Uma is just going to going to show CAT data. The child has been, or the patient has been catheterized. Is there any point of catheterizing him?
Echo because of the PR gradient, it is definitely severe PAH, but because both the arteries are arising from single ventricle, so I don't know how much reliable that we should treat as severe PAH. And the patient is also having restrictive VSD. So
are you doubting severe PAH?
No.
See, patients, whatever you may say, his PA pressure is same as aorta because it is the same ventricle supporting both the circulation. So there's no question about him having any less pH than aortic pressure. His systolic PA pressure is going to be exactly the one which is aortic systolic pressure. Diastolic and may be different, but systolic will be same. So there's no question about PA pressure being not systemic.
Ma'am, one thing we can know extra from CAT data is we can find out the PVH, ma'am, by finding out the LVDP or pulmonary capillary
How
wedge
does
pressure.
it help you in terms of his management?
If it is very high, then if you relieve the restriction, maybe the pulmonary artery pressure because of the retrograde, because of the high PVH also, that can be relieved somewhat.
Yes, so here the problem is of a restrictive VSD, and that is the reason why you want to study him and see if you can do something to him, because otherwise in Eisenmenger syndrome, short of lung transplant, there's nothing more you can offer them. But here is a little different situation. It's not such a classical Eisenmenger that you often see. So
after seeing all these things before this CAT data, that is not required at present. Can you explain now the presence of LVH, why it is there?
Sir, there is clear-cut restrictive VSD with gradient of around 80, with systolic blood pressure on upper limb was around 120, sir. So likely LV pressure
this is acting as a LV outflow, and that is obstructed.
It is like
so that is the reason of LVH.
Yes, sir.
Only there is, with such restriction and such a high LV pressure, sister, there is what you call there is a diastolic overload kind of an LVH. That's about all. I think which is a little. Maybe we could have.
No.
There is.
We have not seen any LV strain in the ECG.
Not seen any strain in the ECG.
7 minutes left for this case.
Uma, go to the cath.
Yes.
Do you think any other non-invasive investigation is required for this patient? Cath is okay. We know that we have to decide the operability and what should be the operation. But do you think any other non-invasive investigation is required in this patient?
Sir, I think most of the data we got from the ECG, X-ray and echo, sir. And maybe if the patient is going for surgery, but here is we are more in favor of to look for the restrictive VSD, sir. Like to whether we can do restrictive VSD to open it, or we need to create an extra VSD. So unlikely some other non-invasive test will be helpful, sir, other than CAT data.
Okay, thank you. Please go ahead.
So here on CAT data showing SVC saturation of 59 with RA saturation of 57, and there is a significant step up of around 14% from RA to RB, and RB to PA around 74 to 85, with systemic saturation is around 83% cyanosis. With RB pressure, there is a significant gradient between the RB and LV systolic pressures, 134 to 230, almost 100 mm of Hg, with slightly elevated RB EDP with high normal RA mean. And the pulmonary artery, the mean pressure was around 86 mm of Hg, which is indicating severe PAH. And systolic pressures, pulmonary artery pressures are almost equal to systolic pressures, sir. And LVDP is elevated, sir, around 20 with pulmonary artery capillary wedge pressure of 18. So likely 12, 13 to 18. Mild PVH is there.
So do you think the echo and the CAT data are concordant?
Yes, sir. Almost there where we got around 90 mm of Hg gradient from between the LV and RV. Here it's almost same, around 100 mm of Hg.
Only thing that JVP in this high pH situation you could not see. This is a bit unusual situation. At least a prominent A wave is expected.
So JVP is not elevated.
Uma, do you have NGOs or no NGOs?
No, ma'am. No.
No NGOs were done.
No
Okay,
NGOs.
Vijay, I think the final question is, what would you do for this patient?
Ma'am, because of the high gradient between the LV and RV, so we can increase the size of the VSD, or we can create one more VSD to relieve that obstruction. By we can decrease the PVH. That we can do, and we can start because of severe pH, we can start a vasodilator along with vasodilator therapy.
Yeah, it is unlikely that he'll be operable in terms of total correction.
So, do you think that the operation, with or without operation, the lifespan would be the same, or any improvement in the symptom? Why are you operating? Sir, are you going to change the natural history in this patient?
Yes, sir. If Eisenmenger physiology, when compared with idiopathic pulmonary artery hypertension, Eisenmenger syndrome has got good prognosis, sir, when compared with idiopathic pulmonary artery hypertension. So making the Eisenmenger into like idiopathic pulmonary artery hypertension will be worse situation, sir. So we should not intervene here. We should not do complete repair here.
What are the risks of this surgery that you're suggesting?
Ma'am, during a surgical procedure, there can be dehydration, there will be increased risk of...
Specific to this patient.
Ma'am, while creating VSD or increasing the size of the VSD, there can be a chance of complete heart block.
Yes, very high chance of complete heart block.
Yes.
Any other question from the experts?
There is, meaning this, what kind of a risk would be there for the surgery? What is your surgical experience tell you that what kind of a risk would be there here? High chance of complete heart block and everything. Like what Dr. Arup Das Biswas asked you. We will change the natural history of this disease. Will more important symptom relief wise. His NYHA class 2, yeah, right? If at all, what is this surgery going to offer in terms of his symptom relief? First, let's talk about that, then the natural history. By enlarging the VSD at the cost of complete heart block is what Madam also suggested. And of course, his risk for the surgery itself, even if he doesn't get complete heart block, what kind of a risk is there for the surgery itself?
Surgery also, Eisenmenger syndrome with surgery is high risk, sir. High risk,
right? And to do a surgery which is not eventually going to change the physiology. What if we leave him to the natural history versus we offer him the surgery?
Yes, sir.
He's not so symptomatic. Does he require a diuretic and things like that in the history?
No, sir. He is NYHA class 2 static since 7 years of age. So unlikely he needs diuretics.
I think the other option for you is to wait, because his left ventricle might just start failing at some point, and then you wouldn't be able to do anything. So you can closely follow him up. If his LV shows any sign of fatigue, that may be a point of enlarging his, because it's like a severe AS that he's up against.
Exactly.
So you can relieve that. We were even contemplating, doing it in the lab, stenting the VSD. With a stent.
I was thinking aloud.
Simply because, as you said, Dr. Kerkar, that the surgical mortality, surgical morbidity is going to be high in this particular patient because of severe pulmonary arterial hypertension. So it's a difficult case. One could wait, not do anything right now, but once his LV tends to get dilated or dysfunctional, I think we'll have to act before that. Otherwise, his natural history is much worse than that of an Eisenmenger per se.
Absolutely.
I think the time for the case is over. And we had a very extensive discussion on this. So,
are you happy with that?
Yeah, but just like an exam has People do ask, you have asked in that fashion, and that is actually what is warranted.
Real googly, it was more a what you call exam of the examiners, which I quite
And from the examiner's point, I thank the presenters, particularly the boys and girls they have presented, and also the faculty from our side, and Dr. Guha for arranging the session.
Dr. Uma is a faculty, is it? Because that echocardiography was excellent.
Vijay, thank you very much. Thank you very much for presenting.
Thank you, sir. Thank you.
And Dr. Uma, thank you very much for presenting the investigations.
Thanks to the co-examiners also. Yeah.
Thank you.
So let us move to the next session.
What is the level of audience at present?
I have not checked. I will let you know later on.
Okay.
Now